So I'd like to invite the rest of the panel that's going to be working in this session to come on up. So what we're going to be talking about in this session is really highlighting some practices that are currently in place that have been around workflow redesign with the goal of improving clinician well-being, enhancing joy in practice, reducing documentation burden, and talk a little bit about how to implement these in a local level. We have a large panel, so we're going to move briskly through the content today, and then we're going to have a short transition break and go into some breakout sessions where you will have an opportunity to interact with a lot of these panelists in more detail. So each of us are going to try to get our example into about 10 minutes. You're going to hear from 5 different examples. You'll hear, I'll go first, and then we will have Jay Batt. What order we're in? Yeah. He is the Senior Vice President from AHA and the Chief Medical Officer and President at HRET. And he will be sharing some examples, and then we'll move to Andrea Barandi-Ketz, who's a lung cancer and patient advocate, and she'll be giving us a perspective as well. And then Susan Corbridge is the Associate Dean for Practice at the College of Nursing at the University of Illinois at Chicago. And then Laura Neville, who's the Chief Nursing Information Officer Consultant at Erlanger Health System. So those will be the 5 examples that you will hear from, and then we will ask Rahul Sharma, an emergency physician-in-chief at New York Presbyterian Weill Cornell Medicine, and Rebecca Shunk, the physician co-director of the Center of Excellence in Primary Care Education and the Associate Chief of Staff for Education at San Francisco VA Medical Center, to give some reaction to what they have heard from all of these examples. And as I say, we'll move fast, and I'll take the first challenge of trying to go through that quickly. Just one clicker. So, as I mentioned, I'm the Chief Nurse Executive at HCA Healthcare. So it's a large organization that spans 20 states and 178 hospitals. And so we took on this work of redesigning clinical documentation. We started from the nursing perspective because we did things a little backward. Our nurses actually started and became completely electronic in their documentation about 22 years ago. So we have a long history, and we did just about everything wrong that you could do wrong. And so we have spent the last 22 years undoing that and redoing it. So our vision was to create a patient-centric record that would guide and inform the provision of safe, effective, and efficient care, to support interdisciplinary care, and to produce data that would help us take care of the patient who is in bed in front of us right now and all the patients that came after that. The imperative we put in our business case was all around reducing documentation burden, and we measured that in terms of time. This was a direct response to our employee satisfaction surveys, where for many years it was the number 2 source of dissatisfaction from our nurses. And so the whole idea was we would return time to caregiving, and we would see the impact of that in our results. So the first point I want to make is this was a long journey for us. We started in 2007, and we are finishing next month, okay, in terms of the design, development, and deployment of this. So this is a long time, stay the course kind of work. We began in 2007 by identifying ideal workflow. Because one of the things we always say as clinicians is the computer should support our workflow. We shouldn't have to change our workflow to go with the computer. But when you have 178 hospitals and 87,000 nurses, we cannot support that many workflows with a documentation system. So we've got to get to what is ideal. And actually we got there very quickly. We came to consensus with large groups of clinicians in some focus groups and some long conference calls. They actually came to agreement on what ideally we would all like to be doing very, very quickly. I will point out that this system is in Meditech Epic and the Meditech 6.0 platform, so it is pretty vendor agnostic. A key part of our success was how we defined responsibilities. We put the nurse executives in charge. They are the ones who set the goals, who set the vision, who settled all disputes along the way. Then we had our technical team, which was our IT colleagues, many of whom were clinicians, but we told them they didn't get to be a clinician in this project. They needed to be IT experts and help us with the design and the development and the programming. And then the clinical team were bedside clinicians, not clinical specialists, but bedside clinicians who helped us guide that. And then finally, a topic that we've all talked about is regulatory, and how does the regulatory impact on the redesign work that we would all like to do. We created a team of subject matter experts who are our internal regulatory experts, risk managers, lawyers, those types of people. We met with them one time, okay, and told them their role, and we never met with them again. They got a spreadsheet, and the spreadsheet had the question that had come out of one of the teams. They had to cite the reg, they had to actually put the reg in the answer that they gave us, or the case law, or whatever it was they were citing of why this rule had to be there. We got to where we started calling them the Mythbusters, because we found out that most of the things people thought were a Joint Commission requirement or thought were a CMS requirement really weren't. It was old knowledge. The other thing that our steering committee did was come up with our guiding principles, and these are the guiding principles we used in the development process, that it would be evidence-based, not consensus-based. We would use a very small design team to come up with what we thought should be, and then we would have a very large review group where everyone could throw tomatoes at it if they wanted to. The practicing clinicians define the content, regulatory experts evaluate the content for compliance, and that's it. We don't care that you used to be a nurse 25 years ago, it doesn't count now. And then we adopted a standard taxonomy that would allow us to reuse the data. So we use the clinical care classification system in ours so that our data is comparable internally and externally. In terms of the design, these were a few design principles that we still use when people come to us and say they want it changed, which, oh, by the way, you know, clinicians are continuous improvement thinkers. The list of changes they want is unending. And so one of them was, we are focusing on the ethical, competent clinician. We are not trying to trick someone, we are not trying to find someone cheating, and we're not trying to teach a student. We are talking and designing for people who already know their job. We're supporting that ideal workflow. We automate the data entry whenever possible, and I'll give you an example of that. We share content between clinicians. It goes back and forth so that they do not have to re-enter data or ask the patient questions over and over again. We incorporated decision support wherever we could. A key one for us was using the software as designed. So whenever you start doing fancy things to trick the software, it means you can't take the next update, and you fall further and further behind. And then we developed a very strict style guide. So we actually only have 6 screen designs, which really simplified training and simplifies maintenance of the system. So these are the results that we got. When we measured just 5 different documentation routines that nurses do, we saw anywhere from a 26 to 41 minutes per 12-hour shift time savings per nurse. Okay, just on these 5 that we measured. If you go around and ask the nurses and survey them, which we did, how much time do they think they're saving? They say anywhere from 1 to 2 hours. I don't really think it's 2 hours, but if they do, I'm happy. And this is some of the quotes that we got from them on those surveys, but I really liked the one where it says, "I feel like a nurse again. Treated like a professional, I'm more able to chart in real time, doing the little things that before I forgot or just didn't get to, and that makes me want to go the extra mile." So that's really what we're talking about. That is not a burned out nurse. That's a re-energized nurse. So these are some of the things that we think resulted in those time savings. One was a focused plan of care. Too many times we are still using the plan of care like we did in school, where let me talk about every potential problem the patient might develop while they're in the hospital. And with a 3 to 4 day length of stay, we really need to focus on the problems we're going to address right now. Limiting the amount of documentation we do for others. I think case management and anesthesia suffered the most, okay? Because no, we're going to ask how many steps do you have in your house of every single patient who comes through the door. If they're going home with limited mobility, then we can ask that later in the place. Removing non-value added content like the inventory of belongings. You know, I don't care about your iPad, your iPhone, your whatever. I'm just going to tell you, you keep it at your own risk, okay? And you may lose it. Sharing content among the care areas, so when the patient comes in the ER and we do some of this history and we do some of this physical exam, that information comes forward if they are admitted. the 6 screen designs I missed, and then interoperability with some of our devices so that we could reduce the nurse as the human in between the data transfer. So this is an example of when we moved to vital sign machines that had Bluetooth technology on them so that as they take the vital signs, it's automatically uploaded into the EHR. We saved 30 minutes of time for every vital sign round, whether that was the nurse or the tech doing that. That's in addition to the 30 minutes that we also got out of the documentation. We eliminated all data entry errors, and we actually had data about vital signs now available for real-time decision support for the care team, when before it was kind of put in later whenever I could sit down and chart that data. So this is some of the things that are coming out of the data now that we have this standardized data. One of this is looking at action type. So this is just my hospital since they went live, so it's an uneven number, but there's 781 million action type data points have been documented during that time among about 100 hospitals. And what I love about it is it's really clearly identifying what we call the cognitive work of nursing. So when we're trying to talk about how do we know how many nurses we need, counting how many meds they have to administer or how many procedures they do really doesn't get us there because there's all this other cognitive work that it's hard to count, but now we have a way to count it. We see that the patient populations are different. They're different on different types of units. The types of problems that the nurses are working on are different. This is a guide to how do we want to plan our education, how do we want to make sister units for nurses to go back and forth. And then finally, we can now pull that data up into key process indicators for things like CODI bundles or C-diff bundles and actually see if the different steps of the bundle are being done. They're being done consistently. You can keep clicking on this until you get down to the individual nurse's name. And you know, do I need to just go talk to Jane about doing a better job, or is this a systemic problem on one unit or more? So key to us, after all this huge investment of all this time, is keeping the gains, and that has involved both setting up a process for people to give input to all that continuous improvement they want to do, and a process by which we formalize the approval of that and decide, is this really a computer problem or is this a workflow problem? And sometimes it is one and sometimes it is the other. So that is our Exhibit A, and we'll turn it on now to Jay to talk about another example.